45-year-old man presents to the emergency services with a massive head injury. He shows complete absence of brainstem reflexes on repeated physical examination. So no response to noxious stimuli in the cranial nerve distribution. An apnea test has no respiratory effort. Neurology was consulted and determined that the criteria of brain death were met. Which American Society of Anesthesiologists physical status classifies applies to this patient? ASA 4,
6, sir.
ASA 5, ASA 6, ASA 7.
ASA 6, sir.
Very good. ASA 6, C is the answer, correct answer. So what does ASA class V, that is 5E, and class 7 mean?
Moribund patient for in emergency.
Moribund patient for emergency. Class 7?
Brought it.
Yeah? Right. So class E means it's a moribund patient in emergency who is likely to die within 24 hours with or without surgery. Okay, so that is the thing for VE. And the suspense, class 7, there is no class like this in ASA classification, only up to 6 is present. Okay. A 12-year-old girl weighing 35 kg is scheduled for resection of right anterior thigh mass. The surgeon would like a peripheral nerve block performed for postoperative pain control. Which of the following is the most appropriate regional block? Options are fascia iliaca compartment block, sciatic nerve block, lateral femoral cutaneous nerve block, iliohypogastric nerve block.
Fascia iliaca block, sir.
A is the answer. Okay, good, correct. Can fascia iliaca compartment block the nerves as in 3-in-1 block? If yes, what is the difference between the two blocks? What is 3-in-1 block? What are the
Femoral nerve, operator nerve,
Operator and LFC.
lateral femoral cutaneous nerve. Very good. So this is the same as that.
LFCN is paired
LFCN
in not ICP.
LFC is not blocked in fascia iliaca, is it?
No, sir.
No. Then how can the operation be done? I mean, how can the post-op peripheral, because the pain is in the anterior thigh mass. That also will block all the three. The fascia iliaca compartment block has same lumbar plexus targets as in 3-in-1 block. The femoral nerve, operator nerve, and lateral femoral cutaneous nerve block. But the difference is in the technique. It is performed in a more lateral position to the femoral artery, and it aims to disperse local anesthetic throughout the facial compartments formed by the fascia iliaca internally, iliacus muscle posteriorly, iliac crest laterally, and the sacrum medially. Okay? So that is how the whole thing acts. What is L-Ganzori risk index? What is the other term for this index? Anyone heard of this term?
No, sir.
No, sir.
Then there is no point in wasting time. It's a risk index score likely to assess the difficult tracheal intubation. Just like your Alambati score, Neckman-Wilson score, and all that. This has been mentioned in the current Indian Journal of Anesthesia. That from where I picked up this question, because DNB examiners are very fond of asking something from the latest journals and other things, even though textbooks are not showing all these things. So it is also known as simplified airway risk index. Okay, what are the parameters used to calculate this? It's very, very simple. These are the things. 7 parameters are taken into consideration. Mouth opening. So 0 is greater than or equal to 4, plus 1 if it is less than 4 centimeter. Thyromental distance 0 is greater than 6.5, plus 1 6.2 if there is less than 6 centimeters. modified malambati, neck movement, ability to prognose, weight, and history of difficult intubation. These are the 7 things that are taken into consideration to make this allegory sign. So if you have 0 or up to 4, how will it be? Easy intubation or difficult? 0 to 4, ma.
Sir,
0
easy,
to
sir.
4.
Easy intubation.
Easy intubation. So scores less than 4, easy intubation achieved by direct laryngoscopy. 4 to 7, moderately difficult intubation, which may require video laryngoscope. More than 7, very difficult intubation, which may warrant awake fiber optic intubation. Okay. Now you are seeing pictures here, 2 pictures. What are they? What is being done here? What is shown in this picture?
Sir, technique of mask holding, sir.
What is the technique called?
Inhalation and
Inhalation.
inhalation.
CE technique.
No, sir.
CE.
See,
This is not CE. If it is CE, I wouldn't have asked it because all of you know how the C is formed and how the E is formed using. Is it? Are these fingers separate?
No,
Mark
sir.
an E. And is this 2 fingers touching each other to form the C? This is called the glass holding technique of holding the mask in a neonate and an infant. Yes, this is a neonate, this is an infant, and this method is called the glass holding technique of holding the mask. A 16-year-old patient with status epilepticus following severe head injury is being managed by paralyzing agent and kept on ventilator. During clinical examination, the treating provider, that is the physician, notices synchronous rhythmic constriction and dilatation of both the pupils. What is the next step in the management? Options are ocular ultrasound, CT head, MRI scan, bedside EEG. Patient,
I see.
examine the pupillary reflex, there is an alternate rhythmic constriction and dilatation. Bedside EEG, good guess, very good. That is the correct answer. Why? What is the term used to describe this rhythmic constriction and dilatation? Is there any term that is used for this? Right, it is called the pupillary hippus. Okay, the term used for that is pupillary hippus. What is the significance of this pupillary hippus?
Ongoing
Presence of refractory non-convulsive status epilepticus. Even though patient has now stopped throwing a muscular contraction, it is a refractory non-convulsive. There is no muscle twitch or contraction, and the status epilepticus is continuing in this patient. This pupillary reflex, sorry. And it's a reliable bedside neurological sign in monitoring epilepsy in paralyzed patient, because you have now paralyzed the patient with a neuromuscular blocking agent. So you do not know whether the epilepsy is controlled or not. So by the EEG as well as by this eye reflex, you know that his epilepsy is still going on, even though he is not showing a muscular contracture or a tonic-clonic convulsions is not there. How does EEG help in this situation? Of course, it assesses the effectiveness of anticonvulsant therapy and to rule out subclinical seizures. Okay, that is how it is helping. What do ultrasound, CT, and MRI help in? Which are all given here as other options. How do they help in this case?
Provided the history of head injury, we might suspect
Intracranial bleeding. Any intracranial bleeding.
Intracranial brain edema. Okay, identify possible causes of epilepsy. Okay? So any changes in intracranial pressure can be identified using that. What is the drug treatment for status epilepticus? What is the dose and safety precaution in their use? Intensive care question. How do you treat a status epilepticus?
Can give levopril, sir.
Benzodiazepine is
Lorazepam.
the antibiotic of choice for
Lorazepam.
emergent control. Lorazepam is preferred because it is a rapid acting action and dose of 0.1 milligram per kg IV, but no more than 2 milligrams should be administered per minute. The other drug is diazepam, can be given at the dose of 0.15 milligram, just like your cisatracurium, and the maximum of 5 milligram per minute if lorazepam is not available. Okay, so these are the two drugs which can be used to control the epilepsy immediately. What is hypotension prediction index? Heard of this term?
No, sir.
If you say no, I will go proceed without wasting time.
No, sir.
No, sir.
Very good. Okay. The hypotension prediction index is a novel hemodynamic monitoring tool that predicts episodes of intraoperative hypotension before they occur. Okay. How it is done? The prediction is done by applying what is called Acumen, Edwards Life Sciences. This is the company which produces a monitor called Acumen HPA software algorithm on data obtained by invasive arterial monitoring during non-cardiac surgery. And the earlier assessment of causes of impending hypotension can be assessed using this. And so this is the algorithm that will be happen. Hypertension prediction index, if you know, then you can assess the stroke volume variation because it's an invasive monitoring. You can assess the cardiac index, you can assess the mean arterial pressure. So if the stroke volume is low, stroke volume variation is low, we go for colloid therapy. If the cardiac index is low, you go for colloid as well as inotrope. If the mean arterial pressure is not maintained more than 70, you go for vasopressor also. Okay, so that is this algorithm can be managed. That is the reason why this has been found. So this is the hypotension prediction index based hemodynamic treatment algorithm. The basis of this is usage of both artificial intelligence and machine learning in the monitoring. Okay? So this again has come in the current journal of Indian Journal of Anesthesia. Assessment of this particular software using comparison between use and non-use cases. And what is DPDT of ventricles? That is the ratio of pressure to time. Excellent.
Complaints.
So it is an systolic contractile function measured by echocardiography. Okay? And normal is 1200 millimeters of mercury, borderline is 800 to 1200, reduced is less than 800, and severely reduced is less than 500 of left ventricle. And the normal is contractility, it is not compliance, okay? It is a force of contraction, that is the pressure developed over a time of the ventricle. And for right ventricle, it is just more than 400. Okay? Left ventricle only has a higher DPDT index. What is shown in this picture? This is not from the current journal, it is a very old physiology question.
To dissociation.
Dissociation curve. Carbon dioxide
Carbon
dissociation.
dioxide dissociation.
Dissociation,
Curve.
yes, correct. Very good. What do points A and B mean in this graph?
A is venous, sir. B is arterial.
Excellent. They indicate the volume of CO2 in arterial and venous blood. How much of CO2 in liters or ml will be there in this part, in this particular levels?
ml.
At 40 ml, 40 millimeters, it will be 480 ml per liter. At 46, it will be 520. Okay?
Okay.
How is CO2 transported in blood?
But
Mostly in the dissolved
three
forms.
forms.
Mostly in the dissolved form. Who is that answering? Yeah, I didn't expect this from you.
3
Okay,
forms.
good. Right, there are three ways. Dissolved is only 5 to 7%. Bound to hemoglobin as carbamino hemoglobin is 10%. Major portion as bicarbonate, 85%. Okay. What is hamburger phenomenon or chloride shift?
So chloride in exchange of bicarbonate.
It's an exchange of chloride and bicarbonate and RBC. Where it happens, you must say. It is the
Yes, sir.
RBCs in the systemic capillaries. When it carbon dioxide combines with water to form bicarbonate and hydrogen ion. So the bicarbonate comes out into the plasma and chloride goes in to maintain the equilibrium. Okay, so that is called, why it is called, which transport protein does this job? Of course, another question is why it is called hamburger phenomenon.
Hemoglobin.
Is it an acronym for this particular process or something else? It is the person who described this, first of all, the scientist, Jacob Hamburger, okay, from, I think he's a German fellow. And which transport protein does this job? It is called the band 3 anion transport protein. Okay. What is Bohr and Haldane effect? All basic physiology, you cannot make any mistake in this.
So,
Okay, right. Bohr effect is when the blood reaches the tissues. In tissues, the PCO2 is more. So it comes to mixes with water, produces carbonic acid, breaks down in the hydrogen ion increases, so pH decreases. This facilitates the release of oxygen, okay, at the tissue level. That is the Bohr effect. Haldane effect, the same thing happening at the lung level. Okay, so what happens in the lung when it reaches the lung? The PO2 is higher, partial pressure is more, whereas CO2 is higher in the blood. So carbamine or hemoglobin dissociates into hemoglobin and carbon dioxide. So because carbon dioxide is higher in the venous blood, it is pumped out, oxygen is taken out. So at the tissue level, this Bohr effect helps in the delivery of oxygen to the tissues. At Haldane effect helps in the elimination of carbon dioxide at lung level. So to remember which is which, Haldane has L. So
L.
the clue to remember is Haldane has L. So this happens in the lung. It helps in CO2 elimination. Whereas Bohr effect helps in oxygenation at the tissue level. So if you remember one, you can make the guess the other one without making a mistake. Okay. What is infographics? This is again from the current journal.
No idea, sir.
No idea. Very good. It's an information in graphic format. All of you are sending WhatsApp with the GIF, isn't it? Graphic in format, like clapping your hands or winking your eyes.
Yes, sir.
அதெல்லாம் நல்லா பண்ண தெரியுது இல்ல, அதேதான். The infographic is an information of graphic in format designed to make the data easily understandable at a glance. So how to make an infographic? You must first outline your infographic goals, gather and organize your data, transform data into visuals, design your layout using an infographic template, add style for a unique lookout, review your infographic design, publish or promote your infographic. These are all the steps that you have to. So this is an example of a infographics. So instead of reading an entire article on ERAS protocol, you can just look at these pictures and the writings on the side, the challenges of ERAS and the opportunities of ERAS. That is the basic of this particular thing. So here you can drive the changes, engage in clinical leadership, use evidence, and reducing surgical stress, standardized protocols. All these things are there. Audit and then monitor, patient center, patient engagement. Like that, all the topics have been made into small pictures and against which the pros and cons are given. Okay, so this is what is called the infographic. These are all the things which are going to be the things of future in all the journals and all the articles that we are going to get in future. This is so there is a full even IJA editor Dr. Rakesh Garg is very much involved in this, and he is producing an infographic every issue and making it more popular among the students and the readers. So people have to be quite updated about this particular technique. So what is shown here, how does it help? This is an infographic of challenges and opportunities in eras. That is the title of this article. This helps to save time by avoiding reading the entire article. What are the types of infographics? And what is the type one shown here belong to means? It can be statistical, informational, or process based. And the graph here, the infographic shown here is informational. It gives you all the information. And it can be about statistics and process also. Now, this is something to check your anatomy knowledge. Okay. Identify the nerve stimulated and describe the motor response to stimulation.
Radial.
All hand movements after a supraclavicular block or a brachial plexus block. If you want to test the motor nerves of various, whether they have been effectively blocked or not, you have to do all this muscle testing. So, which are the nerves that are tested here?
So first one is radial nerve is tested.
This one is radial. Okay.
Yes.
This one.
Extension.
After all, there are
Ulnar
only four
nerves.
nerves: radial, median, ulnar,
Ulnar nerves.
and musculocutaneous. These are the four nerves. No, okay. The typical motor responses to electrical neurostimulation. Radial nerve stimulation results in elbow, wrist, and finger extension. Okay, so this is the radial nerve. Median nerve stimulation causes forearm pronation, wrist flexion, and thumb and finger opposition. You can see this opposition is there, wrist and leg. And musculocutaneous nerve stimulation, elbow flexion. Okay, so elbow is giving flex. And the ulnar nerve stimulation, wrist deviation, little finger flexion, thumb adduction. Okay, we use ulnar nerve for neuromuscular monitoring. So there the thumb adduction is the motor response. Similarly, for the lower extremities, we use 4 P's: push, pull, pinch, punt. Identify the nerves tested using the 4 P's acronym and their motor action.
Posterior tibial nerve.
Hmm?
Posterior tibial nerve, sir.
இங்கே 4 nerves இருக்கிற மாதிரி அங்க 4 nerve இருக்கு. Sciatic, femoral, tibial, lateral femoral continuous. Okay, so sciatic nerve is tested by asking the patient to plantar flex the foot. Okay, and obturator nerve is by adducting the foot, adducting the lower limb. You prevent the adduction, you must bring it to the midline. Lateral femoral cutaneous nerve, you pinch on the lateral side of the thigh, and for the femoral nerve, you try ask the patient to lift the limb by pressing it down. Okay? So these are the 4 tests that you do for the lower limb. What are the phases of clinical trials and their purposes?
Four clinical trials.
Phase 1,
Four
phase 2,
phases. Phase 1, phase 2, phase 3.
phase two, phase
Very
three,
good.
phase
What is the purpose of those 4 phases? What are all the things that are done in these 4 phases?
To rule out adverse drug reactions, maximum drug dosage, to calculate the range of drugs, sir.
Very good. Excellent. There are 4 phases of steps called that. Each phase has a different purpose and helps researchers answer different questions. So phase 1 trial, research drug or treatment in a small group. The number of persons you test will be going on increasing from phase 1 to 2, 3 like that. So first thing is you start checking that in a small group for the first time. The purpose, all the 4 phases safety is the most important factor. Okay, so you start from a very small group, identify the safety and side effects of the drug. Then the new drug or treatment is given to a larger group to expand the number of participants from 100 to 300 to determine its safety and efficacy. And phase 3, the new drug is now given to larger group, 1000 to 3000, to confirm its effectiveness, monitor side effects, compare it with standard or similar treatment, collect information which will allow the new drug or treatment to be used safely. And phase 4, after all this, phase 3 has proved that the drug is effective and safe, then it goes for FDA approval, made it available for public, and then researchers track its safety in the general population, seeking more information about drug or treatment benefits and optimal use. Okay. So what is the term placebo, randomization, and blinded mean in clinical trials? These terminologies are all very well known to you. When you write your thesis, you must have heard about all these things. Placebo is, what is placebo?
Any drug which is not having.
Not a drug. It is no efficacy. It is a compound. You should not say it is a drug. A drug means the drug should have some action, isn't it? It's a compound. Maybe chalk powder, it may be sugar. So a placebo is an inactive product that resembles the test product but without any treatment value. Okay, that is the placebo. And comparing a new product with a placebo is the fastest and most reliable way to show the new product's effectiveness. Okay? Randomization is the process by which treatments are assigned to participants by chance rather than by choice. And this is done to mainly avoid the bias in assigning volunteers to get one treatment or another. Blinded, of course, all of you know that the research team and the study participants both do not know the treatment or that is being given. So this is called blinding, which again is to avoid the bias or the effect on the collection of scientific data correctly, accurately. It helps. How is the safety of participants in clinical trials ensured?
So, whenever there is a adverse reaction faced, immediately like abandon the trial and
You can abandon. You can abandon the trial. That is one of the whole things. Okay, so ethical guidelines are there to protect patients and healthy volunteers. First of all, you must get an informed consent document. The researcher team provides an informed consent, which includes details about the study, the duration, the required procedures, whom to contact for various purposes. Everything is just be given. The informed consent document also explains the risk and potential benefits. And participants are free to withdraw from the study at any time. Not only on some adverse effects, at any time if they don't feel like continuing, they can go away. So they are called dropouts. Okay, and most clinical trials should have an institutional review board, IRB. All of you would have written in your thesis, institutional review board concurrence or acceptance was approved or approval was sought. And IRB is an independent committee that consists of physicians, statisticians, members of the community to ensure that clinical trials are ethical and that the rights of participants are protected. So first step is informed consent. Second step is approval by institutional review board, and the protocols that are to be designed are balance the potential benefits and the risk to the patient. What does protocol describe? It is a goal of the study, whoever is eligible to, who are the participants to take part in the trial, protection against risk, details about test procedures and treatment, how long the trial is expected to last, what information will be gathered. Who is or what is a clinical trial sponsor? So their sponsors may be people, institutions, companies or government agencies and other organizations and are responsible for initiating, managing, financing clinical trial and but they do not actually conduct the research. That is why in all the articles when you read in the journals, there will be one thing called conflict of interest. There won't be, and the sponsors, whether the study was sponsored by somebody or not. That declaration should be present in all the articles when you send an article to you for publication to any journal. So this is going to be the thing. So I thought I'll just include that also. What is this person doing?
Valsalva.
Valsalva.
He's don't say he's smelling something nasty and closing his nose. How should it be done? How do you do the Valsalva maneuver?
Start with a deep inspiration, holding the breath and closing the mouth and nose. Trying to expel with the closed mouth and nose, sir. We might feel a pop-up sensation in nose.
It's called the breathing out in a closed glottis. Forced expiration against a closed glottis after full inspiration to create a pressure of 40 millimeters of mercury and to be held for 10 seconds. Okay, these two numbers are very important. This force you create should create a pressure of 40 millimeters of mercury and the duration should be at least for 10 seconds. Who first used this and for what purpose? Why it is called Valsalva maneuver? That is the person's name. It was first used by Antonio Valsalva, an Italian anatomist, to expel pus from the middle ear. So when you do this, the pressure inside the eustachian tube increases. So any pus that was present in the middle ear, outside the eardrum, that used to be expelled out by this maneuver. What is it used but now for by the anesthetist?
Recruitment.
Huh?
To check for
Air bubbles.
Huh?
to check for any
Bleeding or hemostasis, sir.
rent in the
that
neck
cases.
vessels, sir.
CSF leak, whether it's repaired.
Used to test autonomic function.
function.
Autonomic
Yes,
neuropathy is one of the important things. What are the changes in BP and heart rate in a normal person when they do Valsalva maneuver?
4 stages, sir.
So
Initially,
changes are seen in 4 phases. Correct answer. Phase 1, increase in intrathoracic pressure. There is a transient increase in BP because all the veins will be squeezed into the heart. So venous return increases and so BP will increase. Phase 2, there is a raised intrathoracic pressure is maintained. This will now prevent venous return coming back into the heart. This will reduce the BP, so there will be a compensatory increase in heart rate. And phase 3, the patient releases 10 seconds are over. So patient releases the intrathoracic pressure. There is a decrease in venous return again and decrease in BP. Okay? And the phase 4 baroreceptor sends the fall in BP, help to restore venous return and continue to operate. So increase in BP reflects bradycardia occurs. Heart rate will come down. This is the change that happens in a normal patient. So you can see all this overshoot, everything happening here in the various phases, phase 1, phase 2, phase 3 and phase 4. The abnormal responses happen in congestive cardiac failure, which where will be square waveform seen in constrictive pericarditis or valvular heart diseases. All of them will not produce a fluctuating wheel. It will be like a square waveform. It will shoot up, maintain, and then it will not come back to normal for a long time. And autonomic neuropathy, there is no increase in BP. So diabetic patients, when you do this, there will be no first rise in BP because the baroreceptors are not sensing anything properly, and no change in pulse rate also, and there is no overshoot. Okay. And patients on ventilator and who are hypovolemic, they show exaggerated drop in blood pressure after the release of intrathoracic pressure. Okay. So you can conduct this immune on patients with ventilator by holding the inspiratory hold for 10 seconds. Then you can get this particular response in that. Okay. A 62-year-old man with congestive heart failure, coronary artery disease, hypertension, presents with generalized body swelling and dyspnea. He reports not taking medications prescribed. On presentation, his vitals, blood pressure 110/85, heart rate 115, respiratory rate, I can see that. Oxygen saturation 91% in room air. He is in moderate respiratory distress. Bibasilar crackles are heard in both lung space, and there is a 2+ pitting edema in the shins. Lab investigation show sodium 136, potassium 3.8, creatinine, and brain natriuretic peptide is elevated 2536. Clinical X-ray shows bilateral pulmonary infiltrates. If present, which of the following is an absolute contraindication to initiating non-invasive positive pressure ventilation in this patient? The options are, now first of all, with this finding, what is the clinical diagnosis?
Pulmonary
edema.
Acute congestive failure with pulmonary edema probably. So the chest is showing. So in this patient, to improve the oxygenation, if you want to give CPAP or BiPAP, what are the contraindications? One, chest X-ray showing right lower lobar consolidation, presence of unstable cardiac arrhythmia, need for frequent suctioning due to secretions, abdominal X-ray showing bowel obstruction.
Bowel obstructions.
Need
Wrong
for
answer.
frequent suctioning due to
And
secretions.
unstable cardiac arrhythmia.
B, unstable cardiac
Cardiac
arrhythmia. That is the most important thing. Okay. So that is the important contraindication for CPAP. So the diagnosis of this is acute
pulmonary
hypoxic respiratory failure secondary to congestive heart failure exacerbation. What condition of the patient permits use of non-invasive ventilation? Normally, non-invasive can be tried in what type of patients?
The conscious oriented.
Patients can answer appropriately, demonstrating intact mental status and ability to protect airway. This is very, very important before you think of NIV. What are the absolute contraindications for NIV?
Facial trauma, sir.
Facial trauma, okay.
Unconscious patient.
Unconscious, low GCS.
GCS.
Require emergent intubation in case of cardiac or respiratory error, severe respiratory distress, who have unstable cardiac arrhythmias, and so this is absolute. Relative is facial trauma and all those things. So absolute contraindications are these three.
Yes.
So you are seeing a picture of person holding the endotracheal tube. What is shown here and what are the advantages by the technique in the lower picture?
South Pole
South
RAE
Pole,
tube,
please.
sir.
South Pole. I'm not asking about the tube. I'm asking about patient. What you can see is endotracheal tube is being held in the hand. It is bent like that. It is not a South Pole tube. They have regular class in the endotracheal tube has been bent and held like this.
Anterior larynx, sir.
It is a comparison showing the between the fingers grip and the conventional pen holding grip to hold an endotracheal tube for intubation. Okay? Using the middle finger as a fulcrum provides superior control in directing the endotracheal tube towards the glottic inlet. Okay? What is CHAOS? What is the treatment option? Chaos. It's a confusion. Chaos.
Congenital high airway obstruction.
Congenital high airway obstruction is acronym for congenital high airway obstruction syndrome. It is treated by exit procedure. Ex utero intrapartum therapy is the treatment for this condition. Which conditions are treated by exit? And which anomalies are treated by exit?
Tracheal atresia.
Laryngeal atresia, laryngeal web, laryngeal cyst, subglottic stenosis, or tracheal atresia are treated by exit procedure. What preparations are needed to perform exit? Needs planning jointly by multidisciplinary team involving PT medicine specialist, pediatric surgeon, obstetrician, anesthesiologist. Resuscitation drugs and O-negative leukocyte reduced irradiated cytomegalovirus negative blood for the fetus and group match blood for the partition should be kept ready. How is the fetus kept immobile during the procedure? Is the fetus fully delivered or not for exit procedure?
Sir, fully delivered with the intact placenta, sir.
No. It is not fully delivered. It is delivered only up to the chest nipple level. It will be still getting the circulation from the through the umbilical cord from the placenta. And patient will not be breathing also at the time. Okay, but you require the patient to keep mobile. So that is done by intramuscular fetal cocktail comprising of fentanyl 20 microgram, atropine 20 microgram, vicronium 0.2 milligram per kg, prepared under sterile conditions and then injected into the child, the baby. What is 4-in-1 block? Which 4 nerves are blocked and which surgeries this block is used? Earlier we saw 3-in-1 block. Now they are using this 4-in-1 block for some orthopedic procedures. Heard or no?
No, sir.
Not,
No, sir.
the single injection technique that blocks 4 nerves in the knee. Saphenous nerve, operator nerve, sciatic nerve, and nerve to vastus medialis muscles are blocked. And the 4-in-1 block can be used for knee and below knee surgeries. Why this block is preferred for post-op pain relief after knee surgeries? It's a more of a sensory block rather than motor. Okay, it's more effective than other technique because the femoral nerve block or the adductor canal block alone for pain relief because it is blocking other 4 nerves, and it also makes the patient ambulant much earlier because quadriceps muscle strength is preserved in this. What anatomical level of spread is achieved by this block? Of course, this spreads through the adductor canal in the mid-thigh down to the popliteal fossa. Okay. Which area can be spared in this block?
Remove your charge.
Medial aspect of the knee may be spared. What is IPAC and ACB block? What nerves are blocked by IPAC block and its advantage?
Injection between popliteal artery and the knee
Capsule of the knee. Very good. IPAC stands for that. So LA infiltration in the interspace between popliteal artery and the capsule of the posterior knee is called IPAC block. Adductor canal block is ACB. IPAC injection blocks the popliteal plexus medial to the genicular branch of sciatic and operator nerve, providing analgesia to the posterior compartment of the knee. Okay. It prevents the complications associated with sciatic nerve block like foot drop. And block can be performed in supine position without need to change to lateral or prone position. That is the advantage of these 2 blocks. What is near infrared spectroscopy? What is the theory behind its use and what are its applications? Nowadays we talk of NIRS, near infrared spectroscopy. Where is it commonly used? Which surgery or which surgeons use that? You've not heard it?
Neurosurgeon.
Neuro, regional oxygenation. Okay, near infrared research is a spectroscopic method that uses infrared region electromagnetic spectrum between 780 nanometers to 2500. Whereas our pulse oximetry 640 to
660 to 940.
990.
So this is higher than that. It's based on molecular overtone and combination vibrations. The lower absorption allows NIR radiation to penetrate much farther into the sample. It's very useful probing bulk material with no sample preparation. Applications include medical physiological diagnostic research, including blood sugar, functional neuroimaging, sports medicine, village sports. So many things are being used, both medical and non-medical. And even they are using in arthroscopy to assess the strength of the cartilage. And other areas where it is used is pharmaceutical, food, agrochemical, etc., atmospheric chemistry. What is the use of NRIs in anesthesia? Can be used for monitoring cerebral oxygenation in critical care and anesthesia as a non-invasive insight into regional cerebral oxygen saturation. So nowadays we have that monitor itself available by Massimo. So just like this monitor, you apply these electrodes on the forehead. So what is shown here is the Massimo O3 regional oximetry system. That is the name for that. With advanced multi-wavelength technology, it affects the the extracerebral contamination from tissues such as scalp can affect the NRI's accuracy. But it's already in the market, which can be used to assess the oxygenation of the brain. What is shown here?
Neuromuscular junction.
Neuromuscular
Very
junction.
simplified diagram of neuromuscular junction. Describe the neuromuscular junction. What are all the components?
Presynaptic terminal, synaptic, and postsynaptic terminal.
Synaptic cleft, not synaptic. Just the synaptic cleft is there. So it is, consists of nerve terminal, synaptic cleft, and motor end plate. Post terminal. What is the size of the synaptic cleft? Yeah,
2.4 micrometers.
it is 20 nanometer big. Okay. How many acetylcholine receptors present at the motor end plate? The number
1 million.
1 to 10 million are present in each. What are the types of acetylcholine receptors?
Nicotinic and
Nicotinic and muscarinic. Okay.
Mm.
How many types of nicotinic receptors are there?
Types, sir.
NM and NM.
3 types: pre, post, and extrajunctional. Okay. This is also actually the entry of calcium is also through the receptor inside the globe. How do nicotinic and muscarinic receptors differ in their properties? What type of
Nicotinic or ionic,
ion
channel
channel, ion gated, very good. Ion channel,
muscarinic or G
muscarinic
protein
are
coupled.
G protein coupled receptors. How is acetylcholine broken down?
By cholinesterase.
Acetylcholine esterase broken down by enzyme acetylcholinesterase into choline and acetate. What happens in myasthenia gravis?
Against acetylcholine receptors.
Acetylcholine receptors, very good. It's an autoimmune disease where antibodies are produced against acetylcholine receptors, blocking the action, resulting in muscle weakness. What happens in Eaton-Lambert syndrome?
Antibodies produced against the voltage-gated calcium channel in the presynapse.
So it is in the presynaptic disorder, preventing release of acetylcholine, blocking entry of calcium in the presynaptic area. Okay. This is another new thing which is come in the journal. Because I don't expect you to know. So this is what is shown here is a trial sequential analysis graph. Okay. What is and how is it used? This is used to enhance the reliability of meta-analysis by addressing the problem of random errors like type 1, type 2 errors. And how does it work? Takes into consideration two things: acquired information size and required information size. These are the two things which are needed for this, and target number of participants needed to make reliable conclusions. If the AAS, that is acquired information, and the required information are equal or almost close to each other, the theory can be considered statistically strong enough to make a reliable conclusion. And the trials sequential analysis uses sequential monitoring boundaries to establish whether an intervention is beneficial or harmful, and whether they can stop early the trial study that is going on or proceed with that without wasting time and money. That is the main idea of doing this trial sequential analysis. And the significance of Z graph, you can see here cumulative score, it tells you which is whether it is going to be beneficial or not. Once the Z graph crosses the benefit boundary or harm boundary, we can conclude that the evidence is strong enough to say that the intervention is effective and no further participants need to be enrolled. This saves time and reduces running additional studies which provide redundant information. Okay. And I'll stop with this after already probably 3 hours now. Name the size mark for US scanning the airway of a child. There are 5 locations in dark: 1, 2, 3, 4. Can you name those sites? What is the one? So where is it kept? Huh? It is just at the tracheal level, isn't it? Trachea, superior probe. This is where the
Subcostal, right and left subcostal.
diaphragm. Okay. So this is called 5-point airway ultrasonography protocol. Tracheal scanning followed by sequentially bilateral pleural, that is near the upper lobe, and diaphragmatic scanning. Okay. This probe is placed. Where is the flow? What are the findings to be noticed when the trachea is scanned? The probe is placed over the thyroid cartilage for tracheal scanning and transversely post-intubation. You can see the vocal cords will be separated by the ET tube, and the second parallel air mucosal interface will be seen within produced by the ET tube. How is this pleural scanning done and what findings are confirmed? A linear USG probe in the midclavicular line. You can see here it is the midclavicular line in the second or third intercostal space, longitudinally to visualize the lung sliding and confirm the absence of lung pulse. Can anyone tell me what is the terminology lung pulse indicate USG interpretation? Have you heard of that? Lung sliding, all of
only
you
lung
have heard.
sliding. Yes, sir.
So, lung pulse in US scan, what does it indicate? It's an ultrasound scanning refers to visible rhythmic movement of pleural line on the ultrasound image, which occurs in synchronization with the heartbeat, indicating that the visceral and parietal pleura are in contact with each other, essentially ruling out a pneumothorax. Okay, so that lung pulse, which is mainly because of the contraction of the heart, and that heartbeat will not be transmitted if the parietal and visceral pleura are separated by either air or your effusion or anything. This lung pulse will be absent. So it is one of the methods of identifying the presence of pneumothorax. If lung pulse is present, definitely there cannot be a pneumothorax. And how does the diaphragmatic scanning is done? This is done by placing the probe transversely below the costal mountain. You can see here it is longitudinally placed, here it is transversely placed, and it visualizes the craniocaudal diaphragmatic excursion in response to intermittent positive pressure ventilation or by the breathing movement. And this is the ultrasound picture. Rectal scanning, you find there is the vocal cords are separated, and you find the air shadow here. And this is the pleural scanning, seeing the lung sliding is present, and here the diaphragmatic expression is taken. Of course, the pictures are not good. Right? Shall I stop here?
Yes, sir.
3 hours now. So there are so many another 5-10 slides are there. I think that will take a long time. So we'll stop here. We'll keep for the next class. Okay?
Yes, sir.
Okay, sir. Thank you.
Right.
Yes.
Thank you, sir.